Okay, hello. I see our participants have started to join already. We all seem very eager. I guess the subject on contraception does bear interest in our members. So while we wait, I will ask all of you who are signed in, please make use of the chat function. Just pop us a message with your name and where you are from. We will just allow a few moments for the rest of the attendees to sign in. So those of you online, at the bottom of your screen, you will see the chat function. If you just pop us a message, let us know who you are and where you are from. Okay, I see the chats are coming in. So we have Dana from Johannesburg. I'm hoping I say this name correctly. Ubenita from South Africa. I hope I haven't butchered your name. Sorry if I did. Welcome and thank you for signing in. So for those of you who have come in, we have Vilmarie from Bloemfontein, Ria from Pretoria, Clara from Johannesburg. Good to know that I've said your name right. We have Shannon from Johannesburg. Welcome, everyone. We are just giving a few moments to allow our members to sign in. I do apologize if I missed some of your names. The chats are now coming in very fast. We have Andiswa from South Africa, Nikita, also, I assume from South Africa, Nobisa from Johannesburg, Kamuzi from Johannesburg, and we have Nikita is from Durban. Thanks, Nikita. And we have Jenna, who is from Johannesburg, but studied in Cape Town and now doing community service, her community service here in the Northwest, while you're getting to travel throughout South Africa. Well done, Jenna. We have Sis from South Africa, Larato also from Kwakwa. Welcome, all the way from the Free State. And we have Lerato. I think we will just give it a moment longer before I begin. So a warm welcome to everyone. Thank you for signing in. I'm going to begin the session now. Welcome to the newly launched Golden Key Academy, a place of online learning developed by Golden Key, especially for our members. It has been created in response to feedback from our members telling us that they want more career support and expert guidance. We listened and have created a website filled with videos, articles, and ebooks. If you haven't had a chance to go and check it out, please do so. One of the best things we are offering as part of Golden Key Academy is a packed schedule of live webinars like this one. We are doing our best to select speakers and topics that are relevant to you. So please feel free to give us feedback at any time if you would like to learn anything specific by emailing thoughtleaders@goldenkey.org. Today, we will be focusing on contraception matters. This discussion was proposed to us by Sahil Maraj. Sahil is a final year medical student at Nelson R. Mandela School of Medicine at UKZN. He is currently the South African representative on the Golden Key International Council of Student Leaders. Sahil has been a member of Golden Key since 2017 and has since served as president for the medical school chapter in 2019. Over to you, Sahil.
Great. Thank you so much, Ms. Miraj, for that fantastic introduction. And good evening to all our attendees as well. I'm very glad that we've had such a great turnout so far. To introduce our fantastic expert in the house, Dr. SA Lubelwana. Dr. Lubelwana qualified as a medical doctor at the University of KwaZulu-Natal. She did her internship at the McCord Hospital and did her community service at Usindisweni Hospital and Tongaat Hospital. She then successfully managed her own medical practice for 8 years in the Hammersdale area. Dr. Lubelwana had a special interest in women's health and decided to specialize to become an obstetrician and gynecologist. She successfully completed her master's in medicine and published a paper looking at surgical training of interns in obstetrics and gynecology. She then completed her specialization at the Pietermaritzburg Complex Hospitals and was admitted to the Fellowship of Obstetricians and Gynecologists in 2017. She brings in a wealth of knowledge and surgical experience in her field, which she has accumulated working at Grace Hospital, which is a tertiary level hospital. Dr. Lubelwana has an interest in gynecological oncology and has worked closely with experienced gynecology oncologists, which further enhanced her surgical skills, difficult words to pronounce. In association with the European Academy of Gynae-Oncology Surgery, Dr. Lubelwana completed her bachelor in endoscopy level 1 and is enrolled for level 2. In addition, as a woman, she is well placed to offer professional service balanced with a personal understanding of women, which gives her the competitive edge. Thank you so much, Dr. Lubelwana, for sharing your vast knowledge with us.
Thank you. Thank you for that wonderful introduction. And thank you for the invitation to be a part of this webinar.
Great, it's an absolute pleasure. So just to the attendees, this webinar is going to follow a very relaxed conversation style. Already, we've received quite a few responses from you via the Google form, sending in your questions and your queries. So we will try and cover as many of those responses as possible. If you do have any other questions that you'd like to ask, please use the chat function and we will try to get to them if possible. I'm not sure if you can see on your screen, but there should be a poll up, or it might come up later during the webinar. If you could just please fill in those questions so we could gauge to see how much you know about contraception. All right. So,
Yes.
so Dr. Lubelwana, starting off, as always, ethics is the backbone of any health professional when it's from the time they're a student right up until they're practicing in a hospital level. So dealing with contraception, one of the responses we got was to ask, how do we begin addressing abuse from mostly female healthcare workers leveraged at young women who try and get contraceptives at pharmacies or clinics? I've seen this personally as well, witnessing some of my friends. I mean, the government says, or public health says, go and get contraception, but then that effect is negated by healthcare workers who are stigmatizing these users. What can we do about that?
It is really unfortunate that, that still happens in this day and age, especially when we, as you correctly say, are always encouraging young girls to, once they make the decision to engage in sexual activity, to ensure that they prevent unwanted pregnancies. So it's unfortunate that it still happens. And unfortunately, the only way is to just continually educating healthcare workers and continually, and I think it will look like it's mostly women because it's majority of the healthcare workers that are exposed to these young girls will be women, and the ones who seek contraception will be the girls as well, as opposed to boys. So we are trying to also just merge those disparities where we're not focusing only on the girl, but we're also focusing on the boy child in terms of ensuring that you take responsibility regarding matters of sexuality and contraceptives. It's just that unfortunately, the majority of our contraceptive methods, they are used by the females, So they will be the ones who always go to seek medical help. So they will be the ones who somehow end up getting the short end of the stick. In terms of our healthcare workers, it's just continual education and stressing that, at the end of the day, especially as gynecologists, as obstetricians and gynecologists, what we don't want is unwanted pregnancies. If we prevent unwanted pregnancies, we've prevented at least half the complications that were not necessary. We've prevented half the maternal deaths that, wouldn't otherwise occur if all women who fall pregnant, or the majority at least of women who fall pregnant, have actually planned their pregnancies. So it's just continual education on our healthcare workers and ensuring that when it happens, we deal with it and we follow the necessary structures to positively influence our healthcare workers, our staff members, and continually educate them.
Definitely, that's a fantastic response. And I agree 100% that education is key in changing this perception. And I think that students now who are being trained to become healthcare professionals, they are definitely, in some programs, this idea of removing stigmatization and ensuring fair and equitable access to all without any fear of judgment. That concept is definitely being inculcated into healthcare students now. So that's definitely something that needs to be done. The second question that we have, which I haven't thought about before, is that how can contraception and reproductive medicine be tailored to afford inclusivity and meet the needs of intersex, transgender, non-binary, and gender non-conforming individuals?
Excuse me.
No, are you okay? Sure.
Excuse me, I just need to.
Sure, no problem.
Excuse me, I don't know what happened there. So that's a very important question, and it's very now relevant type of a question. I actually attended a conference in Cape Town in November last year, which was dealing a lot with these issues of incorporating, excuse me, excuse me, I don't know what happened there.
It's okay.
Which dealt a lot with incorporating our medical services and being more gender affirming and ensuring that our healthcare services are tailor-made to broaden the scope as much as possible and to cater for all different types of people as much as possible. Because as it is now, unfortunately, it's really restricted to females as females. It doesn't incorporate the LGBTQIA community. It's not very gender affirming, but there are things that are being done. There are structures that are being put, and that conference was actually organized by the World Health Organization. So there's strides to improve that healthcare improvement. And particularly when you think that at Grace Hospital, we actually had an intersex clinic. So we dealt with patients who were born a certain gender, but identified with being a certain gender, a different gender to what they were born as. And so it requires a lot of multidisciplinary approach, because we had to have the clinic with endocrinologists, gynecologists, plastic surgeons, and urologists. So it depends on what the spectrum is for that particular patient. For some, it's actually a medical condition. So it's things that we just have to incorporate in our setup in our clinics. But as I say, it's more multidisciplinary approach, and we make sure that we tailor cater for all the needs of the patient, particularly when you look at like hormone replacement therapy for example, a patient who wants to identify as a different gender compared to what they were born as, because it's a whole lot of process where they will undergo counseling. And for example, there's a patient who had undergone mastectomy. He was born as he was born as a girl, but he identified as a male. And so we had to go through a whole lot of counseling, and so that we ensure that by the time we get to actual reconstructive surgery, that person has made up their minds for sure. We are sure that he's clear on the decision he's made and the gender that he identifies as. And so he had gone through mastectomy and was on testosterone treatment, and so all of that, it requires a multidisciplinary team, and ensuring that all the needs of this patient are taken care of.
See, wow, that's absolutely interesting. So, I mean, I'm very happy to see that South Africa is actually making strides to incorporate multiple genders and transgenders as well in the future of medical care for the country. That's absolutely amazing. Okay, now that we've got the ethics out of the way, we've now moved on to the crux of our talk, which is the contraceptives. So our first question is, we want to know exactly what types of contraceptives exist and what are the various benefits of them. I mean, as a medical student, I have learned about the contraception, But I'm sure you can definitely elaborate more.
So we've got different types, obviously, of contraceptions, and how we choose which type is appropriate for each person depends on the needs of the patient. There is oral contraceptives, there's injectable methods, there's vaginal rings, there is Implanon, which is the implant that's inserted subcuticular. There's intrauterine devices. So there's various types of contraception depending on what your family planning needs are, what your choices are, and what your medical condition is as well. So it's a whole rigorous procedure. That's why we can't say that a patient can just opt for whatever form of contraception without discussing with their medical doctor, because we need to risk stratify and see which type of contraceptive would actually be appropriate for that type of a patient. And we have to choose the safest type of contraception and taking into account the whole patient profile, basically. But those are the different types of contraceptives that we have available. And there's also benefits that is outside of birth control or sort of family planning. For example, with some patients, it helps with acne. Patients who have PCOS, hirsutism, it can help to a certain extent. Post premenstrual syndrome. So all of those other conditions, contraceptives, particularly oral contraceptives, will help prevention, or let me say risk reduction in terms of development of endometrial cancer and ovarian cancer. So there's other benefits to the different types of contraceptives. So for the younger sort of patients, because that's, I think as much as this is an educational talk, you've labeled it as life skills as well. So I think it's also imparting something to our university going students or soon to be graduates. So just to include those life skills on which types of contraceptives we would choose for people, for example, who are still career driven, who are still in the process of working their way up their corporate ladder or their academic ladder. So long-acting reversible contraceptives are our go-to contraceptives that we, that's always my first line with especially the younger type of a patient. So that would include implants and intrauterine contraceptive devices. The advantage is that they work for a long time and they minimize also the constant or consistent visits to the healthcare practitioner or to the clinics. So it's only for in the beginning when immediately after you've inserted, you will need to go for your checkups, but otherwise the implant can last for 3 years, and the intrauterine contraceptive device, there's different types, they can last up to 7 years. So that's the advantage, that it minimizes that contact, which at the same time will deal with that issue that you brought up earlier in your ethics, in the ethics part, which is the healthcare provider being obstructive to patients who come to receive medical, to receive their contraceptives. So if we minimize that need for repeated visits, then we somewhat dealing with that problem at the same time.
I see. So the implant and the IUD are essentially best for someone who doesn't want to remember to take pills every day. You just leave it in and it does its job. Forget about it.
Yes.
Until, of course, you have to replace it.
Yes, until you just need to remember the dates that you need to replace it. Of course, there are possible complications that can happen, particularly in the first 6 months. I know a lot of people complain, particularly with the implants, that it causes menstrual irregularities. And what we normally do is we say, try it for at least 6 months, because usually after 6 months, your period starts to settle. It may cause a heavy bleed in the initial, like, first month or two. And usually by the third month, it starts to regulate, and it's your body starts to adapt to this hormonal contraceptive, and then it normalizes. But if after 6 months it's still giving you problems, I mean, we always ready to just remove it if it's giving you a problem. So it's not as if you've put it, then you have to keep it for the whole 6 months. No, if it's necessary to remove it, then we do remove it. But we try other methods of trying to control the bleeding before we actually remove it. And the implant, the copper implant, the advantage to using copper, not implant, IUCD, there's the Mirena, which is the progesterone based, and there's a copper, which is, it uses the actual copper as a method of contraception by thickening the mucus plug so that the sperm doesn't penetrate to cause fertilization. So the advantage of using the copper is that your body is still in charge. The hormone workings is still going on as normal. That's the advantage of using the copper over the Mirena. But for some conditions or for some patients, the Mirena is actually beneficial. For example, patients who have endometriosis. It actually helps to curb the symptoms of endometriosis when you've got a Mirena inserted, or if you have heavy menstrual bleeds that's been investigated and there's no cause that has been identified, then Mirena is your go-to sort of contraception.
Okay, great. I see. And you mentioned the copper IUCD. IUCD stands for intrauterine contraceptive device. And we know that that works by creating an inflammatory reaction that prevents the sperm from meeting the egg. Is there any pain during sex for a female who has that device inserted? And does it provide any sort of lubrication?
No, there's no pain. There shouldn't be any pain unless it has either migrated or it's not well placed in the uterus, but it shouldn't cause any pain, which will cause dyspareunia during sexual intercourse. I always tell my patients, because a lot of our women, unfortunately, they're dependent on their partners in terms of which type of contraceptive they want to use, and they wait for their partner's response to know whether to carry on using that method of contraception. I mean, it's good to have that relational basis, but as a woman, as a female, you're responsible for your own body, and the choices that you make should be your own. They should depend on what you want and what you choose at that time. So I always encourage my patients that, you know what, you don't even have to tell your partner if you don't want to. You can tell him if you want to, but you're not obliged to, because this is your body and this is your choice that you have made. So there is no, they won't really feel anything. They shouldn't really feel anything too, because the strings are also so thin that it shouldn't affect sexual intercourse at any point. So if it does, usually there's it's migrated or it's not well placed, and you need to see your doctor. And remember, we always encourage dual protection. So on top of whatever contraceptive method you're using, we still encourage that you prevent yourself from getting sexually transmitted infections, including HIV. So remember that is important.
Definitely something to remember is that contraception does not prevent STIs. The only one that would is if the male wears a condom, or if the female wears a female condom. Is that correct?
Yeah, that's correct.
Great. Okay. Talking about these different contraceptive methods, we know about the fertility awareness method, where you try and time the day that ovulation takes place to avoid having sex on that day. What are your thoughts on that method, and how does it compare to the pill, for example?
Okay, so usually I advise those methods for people who actually want to fall pregnant, because it's good to know, like I always say, women must know their cycle. They must understand their bodies. Every woman must know what's going on with her body. She must know how long her cycle is, when she's expecting her next period to be, so that if there's issues, you know to go and see a doctor as soon as possible. And when you are trying to fall pregnant, the advantage of understanding how your body works is that you will know when you're expecting to ovulate, and that's the time you are most fertile. So that's when I actually advise to use those methods. When you are trying to prevent a pregnancy, those are not very reliable methods. There's more, sort of reliable techniques that you can use. The failure rate is actually, it can go up to as high as 20%, and which is a lot. That's like, that's what, 2 in 10 type of a thing. Which is a lot for a failure rate. So it's good to understand your body and know when to expect what, but it's not very accurate in terms of preventing a pregnancy. Like I say, it's something I normally advise for people who are actually trying to fall pregnant, so that they know when that window of opportunity is, when they are most fertile. Then it increases their chances of actually getting a conception.
I see. So for reliable contraception, nothing is 100% effective, but the best option is to actually go with something that's tried and tested before. I see. And on that topic, looking at combined oral contraceptives, we know that they contain hormones. Combined specifically includes estrogens and progestins. One of the responses we got was someone wanted to know, how does the doctor or the healthcare provider determine the correct dosage of these hormones for you? And could you ever have too much or too little, and how would you know?
So it depends. Like I said to you earlier, we have to risk stratify a patient every time. So we have to look at the risk profile, and we have to look at what other benefits the patient may need from that type of contraceptive. So if, for example, it's a patient that we are also, they want the benefit of a birth control, and they also have a problem with acne. So then we would dose it according to the level of the androgens that we want the patient to get. If it's a patient who, just wants contraception, we try and match it to the sort of normal cycle regulation, cycle hormones in your body as it is. So I don't think we can say you have too much, but we can say that we choose according to your condition and according to your risk profile. For example, a patient who is above 40 years of age, a patient who smokes, or even above 35 now. Before it used to be 40, but now it's 35. That type of a patient, we don't like to put them on oral contraceptives, because they have a high risk of getting thromboembolic phenomenon. So they can shoot up DVTs and have pulmonary embolus and get all sorts of complications. Which is another topic that was actually talked about a lot on Twitter, when I think a lot of women just out of the blue said they're getting embolic phenomenon from oral contraceptives, and which it's one of the possible risk or complications that can happen. But once you've been assessed by your doctor and you've been risk stratified, then you will be put on the correct type of contraceptive for you. So it's not correct to put a blanket statement to say that oral contraceptives cause thromboembolic phenomena. You can get a pulmonary embolus. You will be assessed appropriately and put on the correct type of contraception for you.
I see. And thromboembolic phenomena, are they only caused by the combined oral contraceptive, or does it include the progestin-only contraceptives as well, the POPs?
Are safer for patients who, that's the one we use for patients who are prone to getting thromboembolic phenomena. So that's why I said a patient who is above 35 years, who is a smoker, who is living a sedentary lifestyle, who's got other conditions like hypertension as well, cardiovascular disease or chronic kidney disease, those types of conditions, then that patient we would rather put on a progestin or a non-hormonal even type of contraception. So it's important to go for your assessment before you go on any type of contraceptives. And there's something that you mentioned earlier about the different types not being 100%. One of the reasons I like the LUX, particularly the intrauterine contraceptive devices, that while they are not 100%, they are pretty close. They're like 99.9% effective. So, and we also always say, and I need you to hear this, especially medical students, I need you to hear this properly. If you're on an IUCD and you fall pregnant, the way they are so protective, you are more likely to have an ectopic pregnancy than an intrauterine pregnancy. So if you fall pregnant and you're on an IUCD, the first thing that we want to exclude is an ectopic pregnancy, okay? And the reason I'm saying it's important that you hear this and you hear this properly. A lot of people sometimes they actually think when we say that we are saying IUCDs increase the risk of ectopic. They don't increase the risk of you getting an ectopic pregnancy as such. But if you fall pregnant, you are likely to get an ectopic than an intrauterine pregnancy. I hope that's clear.
Definitely. So you're saying that if you have a normal person who doesn't have an IUCD compared to the person with the IUCD, the only reason the person with the IUCD would actually get the ectopic is because of that contraceptive device, but it's very rare in that sense.
It's very rare that you will fall pregnant on an IUCD, but if you do, it's most likely because it creates an environment that it's unlikely for you to have an intrauterine pregnancy. So you're likely to have an ectopic than an intrauterine gestation.
Okay, that makes sense. All right. Moving on to the next point as well, we know that the two injectables that are offered currently are the Depo-Provera and the Noesterate. The Depo is the 3-monthly and the Noesterate is the 2-monthly. And we also know that currently in government hospitals, Depo is no longer available. So are there any risks switching from, if someone was on Depo, are there any risks switching to Noesterate? And is it as effective as a Depo?
Yeah, so they are just as effective. It's just about ensuring that you follow the correct principles. That's the main thing with all forms of contraception, that you need to follow whatever instructions or regulations that are prescribed by that form of contraception. So like the oral contraceptives, you need to take them as much as possible around the same time every day. And then the injection, if you're on the Noesterate, you need to take it 8 weekly. If you're on the Depo, you need to take it 12 weekly. Now, in the event that you need to switch between these two, is there any sort of problem or complication that you can have? Your body may just respond differently to the one that you're switching from. A lot of people with Depo, they actually go amenorrheic, so they don't have their period at all. With Noesterate, it's like a 50-50. Some go amenorrheic, some actually just have irregular bleeds. So you may just get an irregularity, a shift in the way that you bleed, basically. But in terms of protection, with any change of any form of contraception, we always say just take that precaution for the 7 days. Anyway, like I said, dual protection always. But anyway, just if you're switching and for whatever reason, if you're not using barrier contraceptive method, condom, for the 7 days that you are switching, it's always best to just have that additional cover and use the barrier contraceptive barrier method at that time.
Okay, we actually had one of the attendees who sent in a question saying that they were on depot as a contraceptive, and they started having severe and continuous bleeding, worse than normal spotting that occurs. So this person wanted to know if this is normal and if there's something she could do about it, or if she should go to the doctor and get a consultation. What would you have to say?
So it depends on how severe the bleeding is. If it is so severe that it's actually causing her to not be able to function, then we don't want that. Then we should rather switch to a different type of contraceptive early. But if it's causing some irregularity that can be managed with tablets like cyclocapron or overall, depending on what we have available at that time, if you're using the public sector. So if it's something that can be managed for a period, just to give it, because your body takes time to get used to or to take to whatever form of contraception you are starting. So I always advise people to just give it time, let your body adjust to it. If after 6 months, your body is just not adjusting to it, then it's okay to switch. If, however, the bleeding is so severe that you're not able, that you're dizzy, you're fainting, like it's affecting your lifestyle, then that means obviously you need to switch and change to something totally different. A form of contraception should not sort of be debilitating or give you a poor quality of life. So if anything gives you a poor quality of life, it means it's not working for you. You need to switch to something else that will make you have a better quality of life, so to speak.
Okay. And another very interesting topic to cover, if someone is on contraception and for whatever reason they end up falling pregnant by contraception, are there any legal steps that they can take, and what steps can they actually take falling on with their pregnancy? Are there any risks?
So you mean legal action against who?
So would they have
Against
any legal
the
standing
public,
against
the doctor
public
or
health system or the doc, or even the manufacturer of the contraceptive?
Okay, so if you read even condoms, they come with a proviso that says that it's not 100% effective. Even the IUCD that I was talking about, as much as we say it's 99%, but it's not 100% protective. So there's nothing that we actually say is 100% except abstinence. That's the only thing that is 100% protective. So in terms of the legalities of suing the company is already, they've made those provisions by putting in the package insert, and then the healthcare provider is supposed to also discuss and counsel the patient on the benefits and the possible risk factors. So in terms of suing, I don't think that that is something that can actually, materialize. And then regarding side effects on that pregnancy, so we normally just do a routine anomaly scan at 20 weeks, just to exclude between 18 and 22 weeks anyway, just to exclude if there's any anomalies that may have occurred at that time. But generally, I haven't seen any that have been affected because the lady fell pregnant while she was on contraception.
Okay, so essentially, these companies and the hospital have legal cover. They've protected themselves. Yeah. Okay.
Yes,
absolutely. That makes sense.
Yeah.
All right. And on the topic of cancer, are there any contraceptives that have an anti-cancer benefit?
It's the oral contraceptives that would actually be protective against
Sorry, Doc, we can't hear you.
Oh, sorry. I don't know what
can hear you
happened
now.
there, but it would be, is it better?
Can hear you now.
So cancer of the ovary, if you're using oral contraceptives or any condition, let me say, that causes less ovulation, because one of the theories for cancer of the ovary is that with every time you ovulate, there's changes that occur in the ovary that can lead to, that can lead to progressive changes, dyskaryotic cells that can end up leading to malignancy formation. So if you ovulate less, then that is protective. So oral contraceptives will give that benefit of you ovulating less. And in that sense, they will be protective of both endometrial and ovarian cancer.
Okay, and do these oral contraceptives increase your risk of any other types of cancer?
No.
None. Oh, okay, all right.
You mean
in terms of breast cancer?
Like, oh, sorry. I thought you meant like in the genital tract. Of course, the estrogen dependent malignancies, they would increase the chance of the woman getting breast cancer.
Okay, all right, I understand.
Yeah, that is also another reason why we would, risk stratify the patients, depending on the types of cancer that they also have a family history of or have had previous history of. But estrogen containing are the ones that we would shy away from in a patient who's got a high risk of developing breast cancer.
Okay, all right. We know about the Evra patch. It's a transdermal patch that releases the hormones progesterone and estrogen into the body. It's supposed to be worn for 3 weeks at a time, and then in the 4th week you take it off. If you forget to put it on for 1 or 2 days, is there still a risk of falling pregnant?
Yes, there is. Unfortunately, these methods, they have to work. You have to follow the instructions as prescribed. While the risk will be minimal if it's like 1 day, but the risk is still there. That's one of the reasons why I was saying earlier on that that's the proviso that they put to cover themselves as well, because people's bodies work differently. They metabolize whatever drug that you take differently. So some people will metabolize it faster and get rid of it faster. So you would be open to a possibility of having a pregnancy if you're one of those people who would be metabolizing it much quicker. So it's different for every person, but the safest thing is to just stick to what has been prescribed and stick to doing what has been advised.
Definitely. So it works in the same sense as with the oral pills, in that you have to maintain a certain level of the hormone in order for it to be effective. Okay. One of the responses
that I like.
Sorry.
I just saw a question that I like regarding HPV. One of my favorite topics to talk about is HPV vaccination. I think the question was, I can't see it now, but I think it was something like, how can you, or what are the benefits of actually taking the HPV vaccine? So it's to prevent development of cervical cancer. And the best time to take it is before sexual debut, so before you have any sexual encounter as a girl. So that's why the drive to actually give young girls between ages 9 to 12 before they are actually exposed to the HPV virus. But if you miss that period, you can still take the vaccine, but of course it's not as protective as someone who actually hasn't had any sexual exposure. Up to the age of 26, you can take the vaccine. And in discussion with your doctor, some people can actually use it. I know the American College of Obstetricians and Gynecologists, have added age 45 to possibly use the HPV vaccine. And that's to those patients who are at very high risk of developing cervical cancer. So it is protective of cervical cancer, anogenital warts, and other sort of benign HPV warty conditions that it can cause. And it's not only girls who actually we advise to take. Because of the nature, we said we are, our society is more now gender affirming, and people have different sexual practices than before. So boys as well need to take the HPV vaccine because they can develop anogenital warts, and some people have homosexual relations. So it's protective for all. And the other sort of things I'll say is that even the girls, when they engage in sexual intercourse, it's not by themselves. It will be with boys. So that is why we say everybody should get the HPV vaccine, whether you get into a heterosexual or homosexual relationship, but everyone should be covered and protected against either and it depends on which vaccine you're actually using, because there's the bivalent, which protects against the 2 high-risk types, and then there's the quadrivalent and the newer one, which has a broader spectrum of protection. But whichever one you get it.
Okay, thanks so much for that question. Moving on with on the topic of our contraceptive talk, we know that contraception post-natally after birth is a very important topic, and there's obviously risks in the immediate 4 weeks after giving birth. That reason because we have an increased risk of developing thrombosis and embolic events, normally in the first 4 weeks, you don't generally prescribe something that has estrogen. But for a mother of a 6-month-old baby, what are the contraceptive options for her?
Mother
of a 6-month-old child?
Yeah. So it's either you get immediately after delivery, like within the first 48 hours, something like an IUCD or an implant. But as you correctly say, we don't recommend use of contraceptives that are high in estrogen, because pregnancy itself increases the risk of getting thrombosis. And the puerperium, which is the period immediately after delivery, up to 42 days or up to 6 weeks, you're still at high risk of developing thromboembolic phenomena at that time. So we don't generally advise the use of high or combined oral contraceptives, for example, which have estrogen. So during that time, some people just use breastfeeding as a method of ensuring that they don't ovulate, but obviously that goes with its risks, because it's also not 100%. Some people just abstain during that 6-week period, and then they just get their contraception. Otherwise, the safest would be to use the progesterone, the progestogens, basically.
So the progestin only pill is essentially for that.
Yeah.
Okay, I see. Pivoting now on to, sorry, did you want to say
low estrogen in a patient who has been properly assessed, you can use the very low estrogen dose contraceptives, but we're really shying away from using them.
Okay. Pivoting on to the side effects of contraceptives. We want to know which contraceptive offers the least side effects, especially when it comes to things like acne and weight gain. What are your thoughts on that?
It's difficult to say, because there's no one size fits all. What works for you will not work for the next person. What works for me will not work for somebody else. It's a trial and error sort of method. And you, as much as when we risk stratify you, we can somewhat predict which contraceptive will not work for you. But when we actually put you on the contraceptive, to know how your body is going to respond to it, we can't exactly know how that's going to pan out. So we try whichever method that we believe is going to work best for you and hope that it does. And like I said, the best thing is to give it at least 3 to 6 months for us to know that, you know what, this method of contraception is not working for you. In terms of the least side effects or risks, so it depends on what you looking at and what your condition is at the same time. Like I said earlier on, if you want something that's not really going to be to sort of take over, not take over, but to be hormonally based, then your copper IUCD is the one that you would go for. Otherwise, it also depends on what other condition you have. I mentioned earlier that for patients who have endometriosis, for example, then certain types would work better, like IUCD and Mirena would work better for that type of a patient. So it's all about risk stratifying, but there is no saying that this one has the least side effects for this type of a person. I think I'm losing you a bit. Can you still hear me?
I can hear you, yes.
Okay, perfect. So it depends on the patient and their profile, basically. We can't have a one size fits all. And one of the conference that we attended that I spoke about, WHO, they actually want to have a system where a patient can have her, what, I can't remember what term they use, but it's like a self-help or self-initiation type of contraceptive where a patient can just get whatever form of contraception from a vending machine type of situation. So one of the things that we raised with them was that, but it's dangerous because the patient won't know what they are at risk of. The patient won't know what is best for them. So one of the things that we recommended was that maybe just to initiate, to be seen by a healthcare provider, and then for continued, they would have a system where you can actually get it on the vending machine, which is good because it makes it more accessible to patients, and it removes that obstructive barrier of the healthcare worker.
Wow, that vending machine idea sounds really cool. I hope it develops into a safer strategy.
Yeah, if used correctly.
If used correctly, yes. And are there any risks of starting contraceptives from an early age, from a young age? Like, although the goal may not be to have a contraceptive advantage, but perhaps to control acne or to regulate the menstrual cycle?
Okay, so generally for oral contraceptives, I mean, not really, because it balances the hormones. The problem is with the depot, for example. One of the issues that have been picked up is that it can actually affect bone remodeling, so bone growth. So for very young girls who have not reached their maximum growth potential in terms of the long bones, then we don't recommend to use depot. But in some instances, we end up being forced to because it's the only one that sort of lessens that interaction with the healthcare worker. And young girls will complain that, they're having problems when they go to the clinic often to get their oral contraceptives. So, and they just prefer to at least get those 4 visits where they go every 12 weeks. So it's 4 visits in a year, and they're done with it, which is another reason why we actually prefer to use the long-acting reversible contraceptives.
Okay, great. And we just got one of the questions that actually ties in with our next point is, what are the long-term effects of using contraceptives? For example, the 3-month injection or the no-det combined oral contraceptives?
Long-term effects. So it's using the no-det, like it can just be that high estrogen, always having that high estrogen, and maybe developing those thromboembolic phenomenon in the long run. Some people end up having water retention, which translates to weight gain for some people with that water. It's more water retention than it is actual weight gain. What other sort of long-term effects? Sorry, I got disturbed by that email that got in. But what was the second part of the question? Sorry, I got distracted when there's
the second part was, are there any risks? For example, with the depot, the second part was that, is there any risk of not bleeding for such a long time, for 10 years?
Yeah. So the main issue is the return to fertility, because now your body is not ovulating. Your body is sort of controlled by, it's switched off basically. So to switch it back on to that normal regular cycle where you can fall pregnant can take a long time, particularly with depot, using depot injection. Oral contraceptives, usually within 3 months, your cycle is back on if you stop taking the contraceptive. That's why the failure rate is high, even with forgetting 1 pill or 2 pills, because it easily, your system gets rid of it easily and your body takes over. But with the injectables, it can take long for your body to actually regulate itself back to normality. And a lot of patients will have that delayed return to fertility, which is another reason why we don't like to use the depot for a long time. And some patients actually think that it causes infertility, which is not, it's a myth. It doesn't cause infertility, but it causes a delayed return to fertility. There's a difference between the two. So contraceptives don't really cause infertility, but they may cause you to take a long time before you return to being able to fall pregnant again. But it's not that you're infertile. I don't know if you understand the difference with what I'm trying to explain. Which is the other advantage with the long-acting reversible contraceptives, that once you remove the implant or once you remove the IUCD, there is an immediate return to fertility. So you're able to fall pregnant not long after you remove it. That's the other advantage of it, which is why we're moving more towards that long-acting reversible contraceptives.
Okay, so fertility is never lost. It just takes a while to return, essentially.
Yeah.
Great.
Yes.
Okay.
Essentially.
There's also a number of contraceptive users who are on antidepressant medication, as well as medication for acne, such as Roaccutane or Accutane. What would be the best contraceptive that for that individual?
So for Roaccutane, for example, you really need something that is quite effective, that has highest effectivity, because of the nature of the drug. You don't want to fall pregnant because it can cause quite a lot of issues with the fetus and the embryo. So then something like IUCD, that's my go-to contraception, as you can tell.
A gold standard.
So intrauterine, that's like gold standard. That is most effective, and somewhat least amount of side effects as well. I say somewhat because it depends on the patient as well, but generally, on the whole, it has the somewhat reduced side effect profile. So for that type of a patient, those are the ones that we would advise. For patients who are on antidepressants, some of the antidepressant medication can also sort of interact with the contraceptives, particularly the combined oral contraceptives. So in that case, then you would opt for an IUCD, even copper IUCD. That's what we would recommend. And if there's one thing to remember, it's that if we can reduce the number of unplanned pregnancies for any patient or for any person, and then particularly for people who have medical conditions as well, because we need to make sure that the medical condition, whatever it is well controlled before the patient falls pregnant. So if we can reduce the number of unwanted or unplanned pregnancies, then we would have really done a good job.
Okay. Unfortunately, due to time, I was going to ask you one more question, although we have many more to ask. Contraceptives, can they be used to relieve menstrual pain?
Yes, they are used to relieve menstrual pain. Like I mentioned earlier, in patients.
Sorry, Doc, we can't hear you.
Okay, patients with endometriosis, for example, they suffer with severe amenorrhea. So we use it as part of a treatment. A patient who get the premenstrual syndrome as well, and it actually is a wider spectrum of a sort of a dysphoria. So those patients, they usually get quite severe dysmenorrhea. And so we use contraceptives to manage those conditions. And if oral contraceptives don't help, then we usually go to Mirena as our next option. But a lot of patients get quite good relief with Mirena.
All right, great. Unfortunately, that is time. But Dr. Lubelwana, thank you so much for taking time out of your evening to spend with us. And I'm sure that everyone is extremely appreciative of the immense knowledge that you've shared with us today.
Thank you very much for having me. And if I can just add one thing, because I know I'm speaking to students, it's just to say that if you can just take charge of your lives and ensure that with every encounter, whoever you come across with, you impact upon and impart whatever knowledge that you have, so that we make a difference. It takes making a difference with one individual to change the whole world. So
Absolutely.
Let's just try to do the best to make an impact on one person at a time.
Thank you, Dr. and Sahil, for this very informative webinar. I can see just on the questions that we've received tonight alone, there is a lot of interest from our members regarding the subject. What I can do is, for the members that are still online, all of you that submitted questions, if the doctor agrees, I can send through a list of these questions and the ones that you were unable to answer during the webinar. If you can then answer them and we can attach them on the GKA as well as YouTube when we do post this video. So we will try and include a Q&A. So all of the questions that did not get answered will be answered and posted for all of you to get your answers to your questions. We've lost audibility with you, Doctor.
Oh, sorry. I was saying that I'll be happy to do that. I'm happy to answer the questions.
I will send the questions through to Sahil, and once we get the response from you, we will then have it posted on GKA. So to all of you who did submit a question tonight, if you were not answered, your questions will still be answered, and we will post this on the Golden Key Academy as well as on YouTube under the Golden Key Southern African channel. So with that, I would like to thank you for attending, and you are free to leave by clicking on the leave button at the bottom of your screen. Thank you very much, everyone.
Great. Thank you to all the attendees. And I do apologize for those questions which we did not get to. Unfortunately, we were short on time, but thank you for sending in your responses.
Just based on the questions itself, there's a lot of interest. So I think it's a very lengthy subject. And as we've mentioned, we might actually host another webinar similar to this too, as we see there is a very big interest for this.
No, definitely. I think it's a great idea. Okay. Thanks so much, Mr. Miraj, as well, for organizing and helping us to arrange this.
It's an absolute pleasure. Thank you.
Okay. Thank you. Bye.
Bye.
Goodbye. Thank you.
Bye. Thank you.
Thank you.
Bye.
Thanks so much, Dr. Lubelwana. I really appreciate it.
Sure, sure.